Right. I think we have come to the one of the important slides. From the very first, actually, this is the fourth session of webinar. I have been doing it. I've been talking about one particular thing repeatedly. Mood disorders have good prognosis. Recovery is a rule. Recovery is a rule. Recovery is a rule I keep telling about. You talk about symptomatic recovery. Functional recovery generally follows. It has to follow. I'm not going to know. Like, as I told that, I'll make a patient free of depressive symptomatology. And after that, whether he's going to work on or is something which he has to also depend on, we'll help him. We'll guide him. We'll do the great activity, but he has to also look at. So MDD, there are from DSM-5, we can make out 250 subtypes of major depressive disorder, but major specifiers are all these subcategories: MDD with melancholia, MDD with psychosis, recurrent depressive disorder, bipolar depression, postpartum depression, seasonal depression. If I make a clinical diagnosis of any of this in my clinic, I look at all these things. It's a very, very high recovery chances. Doctor, are you talking about psychotic depression with a good chance of recovery? Yes, sir. I'm talking about, if it is MDD with psychosis, it make it prolonged. He may need ECT, he may need a combination of medicines, the duration may be prolonged, but the recovery has to be, majority of the cases, patient has to recover. Patient has to recover. This is a big therapeutic challenge, but patient has to recover. All this. So, when I make a diagnosis of MDD with melancholia, please forgive me if I'm being a little bit too pushy on that. I tell the patient, if there is certain diagnosis of MDD, melancholia, or recurrent depressive disorder, look, you're going through an episode of depression. You have to take medication. You have to take antidepressant medication. I will also send you for 2-3 sessions of counseling. I won't talk about therapies. I'll send you for 2-3 sessions of counseling. If you're comfortable, maybe it's second, third session, or it's one session. Take the medicines regularly. I think last time I was talking about very, very clearly. You have to take the medicines regularly. You cannot miss the tablet even once. If there's a problem, come back to me always. Come back to me always. Give me about a month's time, 6 weeks' time. You're going to be all right. Doctor, can I be all right? Yes. Will I become all right? Yes. Will I become completely free of this depression? Yes. That is what the confidence this diagnosis gives me. That is why I say that this is very, very important, looking into these subtypes. Chronic MDD, by definition itself, is more than 2 years. I will not be able to say that chronic MDD, okay, you're going to recover. I think it's going to be very difficult for me to say that. Why I am stressing this and then specifically talking about it is that if I make a diagnosis of schizophrenia, I don't think I'll ever talk about recovery. A patient may recover. Some of the patients may recover. I don't know. But I don't think I ever talk about recovery. Imagine any one of us. I don't want to be irrationally optimistic. I'm not trying to give an exaggerated positive response to them. No, sir. No. It's not my intention at all. But what I say is that we are all underplaying. We are not confident that we are telling them. Depressed patient is already in the completely down, and then he says a lot of times, yes, doctor, people talk all those things, but I know that I'm not going to become all. No, I know you try to reassure me, my family tries to reassure me, but I'm not. That is the symptom of his illness. That is the symptom of his illness. The suicidality is symptom of his illness. To that patient, just because you told that, okay, you're going to recover, he's not going to believe me. But a ray of hope it gives. When a patient with melancholia comes to me, I say that, again, pardon me, sir. Some of you think that, okay, right, I'm trying to push it. To dramatize it, I tell them that even if you don't want to become all right, you're going to become all right in melancholia. The confidence to me, it's not any clinician's therapeutic skills. The diagnosis, natural course, and we have the medication, the treatment, therapeutic armamentarium we have. Because of that, so all this, I say that patient recovers 3 to 6 weeks. Psychotic depression, it may be a little bit more. 8 to 12 weeks, but he has to recover. There's no doubt. Recurrence is no, let's not talk about it. Next episodes, future episodes, no, it's a later part of it. But this episode, he recovers. This is where I told, current episode, non-specific, I was talking about it, family history and all things. Here, let me tell you, a patient comes to us, all of us have seen, currently he has come, some vague depressive symptoms, he's not very communicative, he's withdrawn, some sleep problem, some appetite problem, is not working, and there are a lot of vague symptoms like aches and all this. He mostly tentatively MDD, depressive symptoms, but not very definite. Patient's history, like MSc, it's not very confirmative. The relatives are not able to give clear history at all. None of the patient relative who came with them, they are not staying. In that kind of situation, when I am not very definite about it, suppose in the past history, I get a clear history. Yes, doctor, in 2013, he had for a brief period of behavioral disturbance, during which time this man was talking about hearing some voices and then somebody doing something and all things. We got him treated, he became all right in 6 months, doctor. A brief period of abnormal behavior, hearing voices, 6 months treatment, he became completely all right, doctor, 2013. Then everything, we stopped medicines, everything, he went back to work and nothing happened, doctor. Again in 2016, he had a similar problem. He didn't have voices, but he was a bit suspicious, doctor. He was not eating, he was not going to work, he was a bit suspicious about things. And again, after 3 months, he became completely all right. 2013, an episode where he had voices, treatment, complete recovery, 3 years without any medication, he was completely euthymic and he was functioning was as it was pre-morbid. Again, 2016, another episode where he completely recovered, and then now for the last 3 months, he has come to you with a very vague clinical picture. If there is no past history, I still make a diagnosis of MDD, but put a query there. And as I told, everything is slow, go slow, try this, try that. Now with these past episodes, I not only start him on SSRIs, and not only start on antipsychotics because there is a past 2 episodes history of psychosis, I will, even if there's any hint of a suicide, I'll straight away go for ECT. But this current presentation, it's nothing very clear cut, but still basing on the past history, I don't even hesitate to put the patient on ECT. Suppose for this patient, there's also family history. His mother committed suicide. His maternal uncle was alcoholic. That closes my diagnosis. I don't even think a second, wink. Straight away, if patient's relatives are willing, I'll go for ECT. And I'm sure 99% I'm sure he is going to come out of this episode also, and then complete recovery is possible. That is the certainty which you get with this family history and past episode, which I look at it is almost like a blood sugar coming from 300 or 400, where it's certain that it's diabetes. It is that kind of a thing, it helps. So with this, on this, now let me see about, last time also I was talking about MDD with melancholia. For me, melancholia is diurnal variation, late insomnia. These are the 2 symptoms. I think I've been taught as a postgraduate, and even now this is the 2 symptoms. But DSM-5 talks about, this is a criteria DSM-5 gives. Loss of pleasure, depression everybody has. Lack of reactivity, I think mostly people have this. No? This is what is MDD. And then distinct quality of depressed mood, I'll come to it later. Depression regularly worse in the morning, diurnal variation, late insomnia. Here one of these, every MDD patient has got loss of pleasure, that's it, one is satisfies. Out of these 6, 3, suppose patient has a marked retardation or hesitation, significant anorexia, excessive inappropriate guilt, without diurnal variation, late insomnia, according to DSM-5, you can diagnose melancholia, which according to me is, I'm sorry, nonsense. No, it's not acceptable, sir. Melancholia is these 2. Without that, you can diagnose. 3, these 3 can be, and then one of these can be. So when I talk about melancholia, when my colleague in Lucknow talks about melancholia, we are talking about 2 different things. That's where the problem is. This is where I say that diagnostic criteria, when they make it, they need to refine that. Of course, The refining keeps happening, and then this is what is going to be the most important thing. So for me, melancholia is diurnal variation late insomnia. Diurnal variation is one of the most almost a pathognomonic thing. It's like a wonderful thing the way the patients describe. Doctor, when I wake up, I feel miserable, doctor. But as the days pass by 10 o'clock, 11 o'clock, 12 o'clock, when I feel better, doctor. By evening, I'm almost completely all right, doctor, but I'm dreaded again tomorrow morning. This is a classical thing. This is a lots of patients with melancholia described. I'm bad in the mornings, by evening. This one is enough for me to diagnose melancholia. If it is combined with late insomnia, doctor, I get up at 2 o'clock, doctor, 1 o'clock, doctor. After that, I don't get sleep. Clinches the diagnosis of melancholia. I don't look at anything. I don't bother about whether they're having depressed mode or not. This is a very, very important thing. This is, yeah, right. Qualitatively different sadness. Yes, this is important. A few patients did tell me about this. Doctor, in the routine life, general situations, the sadness, we all have sadness. I fail, I lose, and then there's some problems, and then somebody's lost and all things. I feel sad. That sadness quality is different from the sadness what I am experiencing right now. That means day-to-day life, psychosocial stress is what is the sadness, and the major depressive disorder sadness, there is a difference. But this, I think, maybe hardly 4 or 5 people told me. We have to be psychologically very sophisticated to talk about it. So this is a more of an, of course, it's a qualitative difference, but at the same time, it's extremely difficult. That is why I said that sweetness, sir, just as an example, I'm telling, mangoes, this is a mango season. This mango, Alfonso, Dasera, all of them are sweet. I think I am sure all of you must have tasted all these different. Suppose I wanted to describe the sweetness of Benisha, how different it is from Alfonso, how different it is. I am sure. Everybody says it's sweet and then slight flavor, slightly sweet. You are not going to give me a clear-cut description of the difference, which I can understand. Of course, this is not alexithymia. Lexicon, words. Thymia, the mood. Alexi, I don't have words to describe my mood. This is a kind of a neurological condition. I put it here. So this is important. This is right. We all know that. But practically, this is not possible for like an average human being to discuss with me, saying that sadness is. You have to be something like like in a wine taster or tea tasters where they can find out that mild difference in the flavors. You have to have. So that is why I put it down. These two are important to me. Melancholia prognosis good, you'll become all right. MDD with psychosis, I think I thought I'll spend a few minutes there. Major depressive disorder with delusions, hallucinations. Here again, mood congruent, mood non-congruent. Here, the reason why I specifically mentioned is that suppose a patient comes to me with a clinical history of for last 8 months, patient is having depression, patient is also having delusions, hallucinations, which are mood non-congruent, mood incongruent. So in the differential diagnosis, it goes for schizophrenia. Differential diagnosis, schizophrenia or MDD with psychosis. Therapeutically, it's very, very important. Okay, quite a lot of times we give ECT and then patient comes out of it, that's a different thing. If you're not giving ECT, if it is giving only pharmacotherapy, there again, this may help me a lot in trying to find out if he has past episodes and this recovery. This may help me a lot in this because if I diagnose MDD with psychosis, my focus will be more on antidepressants. I give antipsychotics also, but focus on that. If it is schizophrenia, I will not give antidepressants, it's only antipsychotics. Okay, if it is MDD with psychosis, the one thing is that you have to give antipsychotics and mostly atypical antipsychotics. But the problem is the duration of pharmacotherapy, generally it's a little bit longer in MDD with psychosis. I personally, when a picture like this comes, err more on the side of MDD with psychosis rather than schizophrenia. Right, quite a few times I have taken the knock in the long run. they turned out to be schizophrenia. But still, I would prefer to err on the side of MDD with psychosis because I would like to give him the full benefit of the treatment with antidepressant plus antipsychotics for a few months before I conclude that, okay, right, this looks like schizophrenia. This is the most important thing here. MDD with psychosis, patient has to be given antidepressant along antipsychotics. Which antipsychotic you give? What is the dose of antipsychotic you give? There are quite a few antipsychotics which themselves induce depression. I put the patient on escitalopram. I also put the patient on risperidone. What is the dose of risperidone? 4 milligrams, 6 milligrams, depending on the hallucinations. I keep titrating. Risperidone itself can. Haloperidol was the drug which was inducing depression. Risperidone itself can induce depression. So on one side, you are treating depression with antidepressant escitalopram. On the other side, you are giving an antipsychotic which is required here, but that itself is worsening the depression. It's art of psychiatry. It's art of psychopharmacotherapy. This is a very, very difficult thing. So you reduce that, there can be worsening psychotic symptoms. You reduce one, there can be worsening of depressive symptoms. Fortunately, at least in our country, we give a lot of ECTs, so they do extremely well with ECTs. Most of the Western societies, they don't give ECT. That's the reason a lot of times they, like either the diagnosis goes as schizophrenia or they find that, like recovery chances are, there's poor prognosis they talk about. For us, it's an excellent. So this is one of the conditions where your therapeutic skills come to the front. You have to balance how much of dose this, how much of dose this, and also over a period of time. MDD usually over a period of 9 months or 10 months, you have to reduce the drug and stop it. Which one to reduce first, which one to stop it? Is an antipsychotic you are going to reduce. Theoretically, it has to be an antipsychotic, but sometimes I found that you stop an antipsychotic, there is a mild relapse of symptoms. So this is a highly, you need the art of pharmacotherapy here to manage this. But at the end of the day, it gives fantastic results to you. Patient is going to become complete recovery. That is something which we have. As I told, that ECT is always there for us as an effective tool in the management. This.